Welcome to Illuminations. My name is Alex, your Assistant Entertainment Director here on board. Very excited that you're all here with us in Illuminations this morning for our first Cunard Insights lecture of the voyage. I'm very excited to introduce our speaker, who is no stranger to us here at Cunard. We keep having him back time and time again. What a fascinating lecturer he is. And he's going to tell us all about his career in aviation. And this morning is a first in a series of 4 or 5 lectures this week that we will be presenting all about the airline industry. So please, can we have a warm welcome for Captain David Henderson.
Well, good morning once again, ladies and gentlemen, and thank you all very much for coming in this morning at 11 o'clock. Those of you who remember to put your watches forward, fantastic. The rest of them will be here at midday, I should imagine, wondering what happened. I don't know if we've got any doctors with us. You don't have to put your hands up, because I don't want you to identify yourself to all the other passengers on board in case they all want to come and consult you about your bunions, your sciatica, your hemorrhoids and everything, rather than going to the ship's doctor. So you don't have to put your hands up, but I always appreciate your feedback on anything, any aspect of things that I say. I like a bit of dialogue. If I get things wrong from a medical point of view, please, please, please let me know. It's been one of my fascinations. I guess I'm a frustrated doctor at heart. But aviation medicine in particular, which we're going to look at today in a fairly light-hearted manner, I have to tell you, is something which has always fascinated me. As it says in the blurb on the sheet there, do we really belong up there in this pressurized cigar tube 8 miles above the Earth? And the answer is no, we don't. We really do not belong up there. When you think it took us 40 million years to get out of the primordial swamp onto land and start breathing air, it's only in the last, 110 years that we've managed to rise above our planet and into space. And seriously, we require life support systems from the moment we leave this planet, going up or down. So we're a pretty inflexible freak of nature, I think. We need support pretty well everywhere we go. Now, when you've been flying, I don't know if this has happened to you, but when you go flying, you know that there's a problem on board when you hear the bing bong. Ladies and gentlemen, if there is a doctor on board, will he or she please make themselves known to a member of the cabin crew? Now, don't worry yet. It's probably not that both I and the co-pilot have eaten the fish which is past its sell-by date. And they're not going to be paging for a hero pilot to come and land the aeroplane for them. We have to eat separate meals on board the aircraft. That is mandatory. Whatever is on offer to eat on board the aircraft, the co-pilot and the captain must eat separate meals, which I'm not sure why we do that, because in the hotel the previous night, we'd probably been out for dinner together, eaten the same thing in the same restaurant, had the same thing for breakfast, so it's a little bit of an overkill, I think. I don't know if you remember, many years ago now, there was a film, and it was called Airplane. And it was a brilliant piece of spoof cinematography of all the old disaster movies when things go wrong on the ground, in the air. And in this one here, this is the trailer for the film Airplane, and it shows you what happens when the captain and the co-pilot have eaten that fish and are incapacitated, and that unfortunate man has to come and land the aeroplane for us. And he hasn't flown for years, and he is terrified of flying.
Stand by for the most extraordinary chain of events ever swept up into high adventure.
Hey Larry, where's the forklift? Forklift! It's over there for the baggage loader!
Airplane is drama.
This is Dr. Brody at the Mayo Clinic. There's a passenger on your Chicago Flight 209er, a little girl named Lisa Davis, en route to Minneapolis. She's scheduled for a heart transplant. I want you to make sure that she's kept in a reclined position and that a continuous watch is kept on her IV.
Airplane is action. Airplane is romance.
I love you, Elaine.
Airplane is music.
There is only one river, there is only one sea.
airplane is dancing. Never has the screen been so big.
You ever been in a cockpit before?
No, sir, I've never been up in a plane before.
Peter Graves,
You ever seen a grown man naked?
Kareem Abdul-Jabbar,
My name is Roger Murdoch. I'm an airline pilot.
Leslie Nielsen,
This woman has to be gotten to a hospital.
A hospital? What is it?
It's a big building with patients, but that's not important right now.
Lloyd Bridges,
Johnny, what can you make out of this? This? Well, I can make a cap, or a brooch, or a pterodactyl.
Robert Stack,
All right, Steve, let's face a few facts.
And we hope you enjoy the rest of your flight.
Julie Haggerty,
By the way, is there anyone on board who knows how to fly a plane?
Can you fly this plane and land it?
Robert Hayes,
Surely you can't be serious.
I am serious. And don't call me Shirley.
I gotta get out of here. I gotta get out of here. Down, get a hold of yourself.
Calm down, now get back to your seat. I'll take care of this. Calm down, get off yourself.
Don't be on the phone. Everything's been
Mayday!
All right, now everybody, get in crash positions.
the most incredible adventure the screen has ever created. The big news is airplane.
I thought that was fantastic. 1980 that was. I just managed to read the Roman numerals at the bottom there. 1980. So it's an old film now, but I think it's still one of the better ones. And I love some of the lines in it. Surely you can't be serious. I am serious, and don't call me Shirley. It's brilliant, that. Now, on this one, what's this thing here doing? Hold on 1 second. There we go. Now, to be honest with you, it didn't exactly happen like that. This is a Mac cartoon in the Express, I think. But it did, and something similar did actually happen at Liverpool, it was. There was a German gentleman who'd been on holiday in England, and in his stopover in Liverpool, he had sadly been taken ill and died. Now, the family were going to repatriate his body back to, I think it was Berlin, and the quote that they had from the undertaker to get the body boxed up in the hold, customs clearance, and then meeting at the other end, was somewhere about £3,000. The one-way ticket cost on EasyJet from Liverpool to Berlin was £29.99. So what they reckoned they would do is they would put the old boy in a wheelchair, they got him a ticket, they put him in a wheelchair, they took him up to the check-in desk, they checked him in. They gave him a boarding pass. They did query it. The check-in staff did say, is your father okay? He doesn't look very well. Looks a bit pale. No, he's just having a sleep. He's okay. He'll be fine. He's just having a little rest at the moment. But in this picture here, the lady is saying to the stewardess, yeah, if you just leave his lunch for him, he'll be ravenous when he wakes up. It was only when the wheelchair got as far as security that the security guy thought, hello, I don't like the look of this. Put his hand out onto the old boy's hand on the wheelchair. Of course, he was stone cold, and they were rumbled from that point on. But the idea was, with rigor mortis setting in, they just lift him out of the wheelchair, put him in the seat on the aeroplane, at the other end, lift him out again, put him back in another wheelchair, wheel him into the building. £29.99, well spent. The other thing that another lady coming back from Spain, she was asking the stewardess if she could get her husband's duty-free allowance also. And the stewardess said, where's your husband, madam? She said, oh, he's travelling in the hold in his box. So unfortunately, she didn't get the husband's allowance. Now, I don't know if any of our doctors on board have had the thrill of being called upon in flight to assist at an in-flight emergency. Nowadays, There used to be problems, especially for American doctors, in coming forward because of the litigation culture in the United States more than anywhere else. Doctors were a bit reluctant to come forward, but there is now what's called a Good Samaritan clause built in, that any doctor coming forward to assist cannot be held responsible for the death of the patient if the patient happens to succumb, unless gross negligence or gross incompetence can be proved, which is very difficult. So people are more willing to come forward now. There's usually something in it for you as a doctor. You'll get an upgrade to first class probably on the next sector on your way home, because we're very grateful. If you save us the price of a diversion, you have saved us thousands and thousands of pounds. So, a quick upgrade and perhaps a bottle of champagne is a very small price to pay for your generous services. Now, I don't have a very good record, I have to tell you. I had 3 deaths on board my airplanes in my flying career, not as a direct result of my incompetent flying, I hasten to add, and only 1 birth. Now, the death I had, we were coming back one night from the Far East back to the Middle East, and a unfortunate little Bangladeshi lady was taken very ill with a heart attack. She died very quickly and painlessly. They paid for a doctor anyway, and this delightful little Bangladeshi doctor came up to the galley and he said, "What is the problem?" And the stewardess said, "Well, this lady here appears to have expired." And they're doing, the cabin crew are doing CPR at this stage, which they have to do for 20 minutes. People have been brought back from the dead after CPR has been applied for 20 minutes. So a little Bangladeshi doctor, he looked for the vital signs, and he said, "You can be doing for 20 years. She is not coming back." But the law says that they still had to carry on doing it. The birth I had on board was quite an interesting one. Again, we were coming from India up to the UK, and this quite ample Indian lady had managed to smuggle the bump on board the aircraft under a very loose-fitting sari, which is, if you've got a loose-fitting sari, you could fit quite a lot of stuff under there. And it wasn't her first baby. She was quite a big lass anyway, so she'd got through the system. She went into unexpected labour somewhere over Yugoslavia when we used to fly up that route. And the cabin crew, of course, paged for a doctor. No takers. Absolutely no doctors on board at all. The stewardess was walking down the aisle and this lady stopped her and she said, "Excuse me," she said, "I'm not a doctor, but I do have medical training if I can help in any way." The stewardess said, "Well, you wouldn't happen to be a midwife, would you?" And she said, "Yeah." I mean, how lucky can you get? This lady had been retired from midwifery for about 30 years, or 20 or 30 years, but I guess it's something that you really don't forget how to deliver babies once you've done it. Of course, doctors are useless when it comes to delivering babies. They've probably never done one since their obstetrics and gynecology 6 weeks in medical school 30 years before. So that was it. She delivered perfectly naturally. We carried on to London. And it was great when I spoke to air traffic control. They said, "What's your souls on board? How many people do you have in board?" And I said, "We've got 392. He said, "It says 391 on your flight plan." And I said, "Yep, that's right." I had to explain to him that we'd had an addition en route. Now, we will obviously have to make an emergency diversion en route for a major medical emergency. If you have had a heart attack, if you are in uncontrollable pain. Now, we carry pretty heavy-duty drugs on board the aircraft, which are for your use, not ours. They're pretty heavy-duty drugs, and they will control most pain. But if, let's say we've hit turbulence, and you have fractured a bone in your leg, you may have fractured your back, and you are in extreme pain, we can administer these drugs. But if we cannot control the pain, then obviously we must get you to a ground medical facility as soon as possible. Kidney stones is another one. If you're in dreadful pain with renal colic, then of course we would have to divert for that. Now, when we decide we want to be pilots, the first thing we have to do before we spend any money is make sure that we are medically fit to be pilots. I mean, you don't have to be Superman, you don't have to be super healthy, super fit, super athletic. I know you might find that hard to believe, seeing this young Adonis standing in front of you here. But that's about it. You don't have to be Superman. You just have to be reasonably fit, healthy, look after yourself, a reasonably healthy lifestyle. So they check for vision, long vision, medium vision, short vision, because we have to be able to see right clearly in the distance. We have to be able to see our instruments, which are about as far away as arm's length. That's about where they are. We also have to be able to read very, very small charts at night with our airport information on them. A lot of this has now gone electronic and it's presented to us on television screens, but they still check for this. The other thing which we have to have, of course, is perfect colour vision. Now, I'm going to give you a little test in a minute, and I usually pick up maybe one or two men who did not know that they had, we don't call it colour blindness nowadays, it's called colour perception abnormality. And to most people, it doesn't make any difference at all. All it means is that you see red and green. That's the most common anomaly. You see red and green in a different way to other people. Now, it doesn't matter to you, even when you're driving, you don't have to see red, amber, green on traffic lights, for example. You might see it as blue, pink, and yellow. It doesn't matter. It's the sequence that your brain will process. So how you see these colors, it really, really doesn't matter. Now, the other thing they do, of course, for us is they have to look at our ears, make sure our hearing is perfect. And what they do is they get one of these little light things and they shine it in one ear. If the beam of light comes out the other, then we've got a bit of a problem. They give us a resting ECG, an electrocardiograph. And when they're happy with the heart's trace on that it's doing all the right things in its working and resting cycles, they then put us on a treadmill and make us run until the heart reaches its maximum output. In the RAF also, they give us what's called an EEG, an electroencephalograph, when they wire the brain up to electrodes. And they check for different aspects of brain activity. If they find any, you pass. They show you pictures while you're wired up to this. It might be a nice landscape, a nice seascape, a nice peaceful thing. They might show you a picture of devastation, of an earthquake or some natural disaster or a war zone. And then occasionally, subliminally, they'll flash in a picture of, how can I put this, a young lady who has forgotten to finish dressing that morning. In my day, it was only a sort of page 3 girl type of thing. I don't know what they show them nowadays at all. See the brain's reaction to this. In some countries, they also put a fibre optic television camera up your nose, which is jolly uncomfortable, I can tell you. They tell you that they're checking for sinus problems, in case you have any problems up in these cavities in your skull. They're not. They're checking for any evidence of substance abuse. In other words, if you recreationally snort white stuff up your nose, they're looking for any damage from that. They do blood tests, urine tests, motion sickness tests, psychological profiling to ensure that we're reasonably mentally stable. Coordination tests, which are now done by computer. In my days, it was a little cathode ray tube with a control column, a joystick and rudder bars, and you had to keep a little spot of light in the middle of the cathode ray tube. That's easy. Anybody can do that. But then, as they see you getting to grips with that, they will then make you do mental exercises as well. Simple mental arithmetic to start with, getting more and more and more complicated. And they want to overload your brain. They know it's going to happen. They want it to happen. It doesn't matter even when it happens. It's how you react to your perceived failure that they're interested in. Whether you accept it, you resign yourself to it, whether you get really angry with yourself, or whether you get frustration, or you lose the plot completely, that is what they want to see. They then take the pressure off you and make sure that you can recover from that overstress situation. So that's the important aspect of that one. What else do we have? Oh, seasickness. That comes a little bit later in the talk. I was going to mention seasickness to you because I know some of you have suffered a little bit with some of the rough seas that we've had. Right. Now, this is a little test that they give us. These are called Ishihara plates. And these are what they give us to initially test our colour perception. Do we see any numbers on here? Does anybody see a number? 6? Anybody seeing anything other than 6? An 8, maybe. 8, yeah, okay, that's not a problem. 8 would indicate that you have a very, very, very mild colour perception abnormality. The number there is a 6. All right, let me just give you another one. Men are much more likely to have colour blindness, colour perception abnormality than females. This is due to our chromosome makeup, our chromosome structure. And women are protected from this because they've got 2 X chromosomes, and they reckon that they have a sort of double backup system, if you like, whereas us blokes with 1 X and 1 Y chromosome, we are more likely to suffer from this. This one here, 74, yeah, pretty good. Anybody seeing 21? Yeah, seeing 21? Did I hear female voices there? Yeah, you're seeing 21. Do you know you're colourblind, madam? Oh, I see. Oh, that's okay. I thought you said you'd seen 21. I was going to say, this one is reasonably straightforward. 74, most people get that one, but some people do see 21, or you might see nothing. You might see nothing at all. I'm not alarming you on this, I hope, but if you're not seeing what I say you should see, next time you see your doctor, just ask him if he's got Ishihara plates in his surgery, and ask him just to run that by you. Last one, 29. That's quite a tricky one, that, actually. If you can see that okay, then your colour vision is pretty much spot on. So, why is this so important to us as pilots? It's not so much the red and green navigation lights, although those are important to us. We don't want to get those mixed up, otherwise we might find that we might think that something is going in the opposite direction to what it actually is. More importantly is the fact that sometimes we rely on coded lights from the control tower. If we've got a total radio failure, for example, we'll get lights from the tower, red and green lights telling us what to do, and we may get pistols fired in the air, firing flares up into the air as well. Now, also on board, of course, we have television screens now. I'll show you a bigger picture in a minute. But most of these are in multicolour, and we've got all sorts of colours: red, green, blue, magenta, brown, what have you. Okay, so on the internal... it's a bit blurry, that one. But anyway, it gives you a general picture of all the different colours that we're going to see on our television screens on the flight deck here. And this one in particular... I don't know why that's blurred. The radar that we see, we now have colour radars, and it's pretty self-evident, of course, that the green part here means it might be a little bit bumpy, there's a bit of rainfall around there maybe. The yellow bit, that means you want to avoid this if you can. It's going to be a little bit more bumpy, maybe a little bit more rainfall. And the red bit, as you might expect, means you don't want to go here. You seriously do not want to be in that piece of sky, because it is going to get very, very bumpy and very, very wet in there. This is what we call our ADI, our Attitude Direction Indicator, better known to you probably as an artificial horizon. That's all it is. But there is so much information on this instrument, from our speed to our attitude to our altitude to our heading. It's all there, and up here it tells us what mode is engaged in the autopilot: the speed, the altitude, the localizer for landing. It's kept simple for pilots, as you might expect. Remember my KISS? Keep it simple, stupid. So they make the top bit blue, which is the sky. We understand that. And they make the brown bit Earth, and we understand that. Now, our job is to keep them that way arranged. Okay? If we keep the blue bit at the top and the brown bit at the bottom, we get paid that week, and we can go home. If we get them the other way up, we spill your gin and tonic, and it gets terribly noisy in the cabin with all the screaming going on, and we don't get paid that month. Our external tasks, those are the lights that we can expect to see as we come down the approach. These are our approach lights, and then at the threshold of the runway we've got green lights, which shows us the absolute end of the runway. Further down here we've got little lights which are difficult to see in this slide. We've got red, red, white, white, which indicates on a normal aeroplane that we are on the correct descent path. This one here on the right, this is our aid to parking the aeroplane at the gate. Okay, we come in and we point the airplane at the building, and then we just move it slightly left and right to make sure that we've got 2 green bars ahead of us. Once we get 2 green bars, we are absolutely spot on the centre line, and then another indication to the side of the airplane tells us when to stop, so that we know exactly that the door is lined up with that air bridge. Quite straightforward, but you obviously turn towards the green. It's sort of common sense. So in that one there, we would turn towards the green, and that one then would also turn green. Now, in our heads, we have got the most phenomenal pieces of equipment known to man. They are absolutely fantastic. I'm going to start off with the ear, which we don't pay any attention to normally, do we? We accept that it's going to work. This is your ear. This is your ear canal coming down to the tympanic membrane or eardrum, and then it goes into the middle ear, into this chap here, shaped like a snail. That's called the cochlea. And these yellow chaps here, these are called semicircular canals, which I'll explain in a minute. So this is a pictorial part of it, and the cochlea, and in these little semicircular canals here, they're filled with fluid. And in these canals you've got little hairs, and on those little hairs you've got little stones on the end. And these little hairs on stones, they move around in this fluid as you move your head backwards and forwards, up and down, side to side. They send signals to the brain. Okay? Now, this in simple terms affects us in what we call pitch. That's when the nose of the aircraft or the ship goes up and down, obviously. The roll is when the aircraft or the ship rolls from side to side. And the yaw, we don't get so much yaw on board the ship because she's carving through the water in a very stable manner. But on an airplane you can get yaw as well, which is when the nose goes from side to side. Now, this is what causes people to suffer from, what do we call it, air sickness. It's not called air sickness anymore. It's called motion discomfort, right? In terms of politically correct. Now, those things that they have around the ship in rough weather, those nice big white bags, they're called motion discomfort receptacles. In the old BOAC, they used to call them cuspidors, which is a very posh name for what we used to call honk bags. Right? It sets you apart. It tells people what class you're from. You know, if you call it a cuspidor, you're obviously terribly high class. If you call it a honk bag, then you're not. Now, I have noticed that a few of you have been wandering around the ship with these little patches behind your ears, the anti-seasickness cure. Anybody use those at all? Oh, nobody here. Oh, that's a shame. And does anybody use the little acupressure bracelets that you get? God, you must all be fantastic sailors. But I was going to say, if you do suffer from seasickness, the best thing you can do before you're seasick, if the captain says it's going to be rough tonight, nip down, see the doc, pay the 30 quid or the $50, whatever it is, and have the injection. That will normally work well for you. You can get stuff over the counter, of course. It's called Avomine. Avomine is the best one to use if you suffer from either motion sickness, air sickness, or sea sickness. That's the way to go, I think, anyway. Now, in your ear also, of course, you have got other parts of it called the eustachian tube. And this is what causes you pain sometimes. If that gets blocked, that eustachian tube, as we're descending, we get increased external pressure on the way down. And if we can't equalize the pressure, that is when we get pain in our ears. Now, the one way round this is either just move your jaw up and down, and you'll feel your jaw clicking a little bit. This is going to move this part of the eustachian tube here, and hopefully just open up that little gap there and allow the pressure on both sides of your eardrum to equalize. If that doesn't work, you can just put your thumb and finger underneath your nose and just blow ever so gently. Don't overdo it. If it doesn't clear by a fairly gentle blow, as it probably will, to be honest, you don't want to push too hard, otherwise you may do further damage. And this is called the Valsalva maneuver, named after the guy who discovered it. Now, you can have this you're more likely to have this if you've got a cold or an upper respiratory tract infection. That can give you greater blockage. And as I say, it can cause severe pain. If it doesn't clear shortly after landing, again, go and see your doctor, because you will be a bit deaf as well as a result of that. If you're traveling with a baby, or see a young mum traveling with a baby, and the baby is crying during the descent, don't don't try and pacify the baby. Don't try and stop it crying, because that's the best thing it can do to clear its ears. Its crying action will sometimes help to clear the eustachian tube for it. As I say, the other thing which we can suffer from is sinus block, which can be excruciatingly painful. I had it once on board the aircraft, and I actually thought that the windscreen had shattered and glass had gone into my eyes. That's how instantaneous and agonizing the pain was. Because it was my livelihood, I had to have the operation to put the problem right. It was just a very, very small gap in my nose into my sinuses, which got blocked, and it might repeat itself. And it is incapacitating for a pilot. So you have to go into hospital for the operation, which is very unpleasant. What they do is they put you to sleep. They get a big Black & Decker drill and stuff it up your nose. And then when they've done that, they get a big wire brush on it, and on the drill, and they shove it up your nose as well into the sinus there and in there, and they clear the whole thing out. And then when they finish the operation, what they do is they pack you with gauze, surgical gauze. They stuff it all up into the sinuses there and there, and then they take you back to the recovery room. When you wake up, there will be about 6 big nurses sitting on you, because when you wake up, you think you can't breathe. You don't have the sense to breathe through your mouth as you're coming round from the anaesthetic, and you feel that you can't breathe, so you fight for your life. And then eventually somebody goes and gets an injection and puts you back to sleep again, so that you wake up a bit nicer next time. About 3 or 4 days later, you're lying in bed minding your own business when the nurse comes in, and she says, "Right, it's time to take the gauze out now." So she puts the television on in the corner. She puts on a DVD with about, 6 episodes of Friends or something on it, and then she starts pulling the stuff out. And about three episodes of Friends later, she's finished that side, and then she starts on the other side for the other 3 episodes of Friends. I don't know which is worse, that or watching Friends. I think I'd probably rather have the operation than watch Friends, to be honest. Decompression sickness after scuba diving. I don't know if we've got scuba divers with us. If we have, they will know more than I do about this, because I'm not a diver. But if you're a diver, you have to be very careful mixing diving beyond a certain depth and then going flying within a certain time period. Now, hyperventilation is a problem to quite a few people in flight, especially those who are a little bit anxious about flying. You tend to overbreathe. This is what hyperventilation means. You overbreathe. And by overbreathing, you wash out what is a very, very tiny percentage of carbon dioxide in your blood. And this leads to more apprehension, more fear, and it's a self-perpetuating problem. You can get feelings of tingling in your fingers. You might start losing a little bit of vision. That can happen as well. As we breathe, what do we breathe? We breathe oxygen, nitrogen, and carbon dioxide, plus a few other gases as well. But our atmosphere, it's about 79% nitrogen, and it's only 20% oxygen. So we're quite oxygen deprived right from the first moment. The way around hyperventilation is to try and get that concentration of carbon dioxide to build up in your body again. So how do you do that? You rebreathe it. You breathe into a brown paper bag and then breathe back in that same air again. That way you'll get that carbon dioxide back into the bloodstream and everything will be restored to normal. The opposite of that is something called hypoxia, which is lack of oxygen, which can happen at high altitude. Our cabin is normally pressurized to between 6,000 and 8,000 feet. Okay? So we might be cruising along at 35,000 feet, but the cabin pressure will be the equivalent of being at the top of a medium-sized mountain, 6,000 to 8,000 feet. If we lose that cabin pressure, of course, we are into the ambient environment of 35,000 feet, which is not a place that we want to be without those life support systems that I mentioned at the start. In other words, pressurized cabin air. Now, in the Air Force, they taught us to recognize hypoxia, and they do this by putting us in what they call a decompression chamber, which is a fascinating exercise. It really is. I'm just going to show you what they asked me to do in the decompression chamber as we climbed up. Okay, it's a little bit faint, but this is the original, going back almost 50 years. So they ask you to do simple things like writing your name, your address, and what have you. And then as the hypoxia becomes evident and your brain becomes less useful to you, then you start scrawling. Now, the danger with this is that in this chamber you do not realize how useless you have become. You do not realize, I did not realize, I thought my writing along here and up here was as good as that one there. I did not, well, as bad, so I've got hopeless handwriting, but I thought this illegible scroll was as good as this up here. And this is the danger for pilots. It's happened on more than one occasion when they have had a problem with the cabin pressurization or loss of pressurization in the cabin. The pilots have not recognized the problem quickly enough. And they're sitting there in the cockpit thinking, God, it's a great job this. God, we're good, aren't we? Fantastic. There's a lovely blue sky. And they just lapse into unconsciousness, and that's the last thing they know on this earth. They will die. Everybody on board that aircraft will die. Now, when these little oxygen masks, which they do in the briefing for you, remember, when the oxygen mask drops down, grab the mask, pull it towards you, put it over your mouth and nose. Do it, please, because if you don't, these figures here give us what is called our time of useful consciousness. Now, these to me are very optimistic. 35,000 feet, okay? We're flying along at 35,000 feet. We've had a cabin depressurization, and it says we have 30 to 60 seconds. That to me indicates a very fit young person. I think people of our sort of vintage, we've got between 10 and 15 seconds to get those masks on because our cardiovascular system is probably not as efficient. Now, in this chamber, what they do, as I say, they give us two runs normally. One is a slow decompression, okay? In other words, we are going to be overcome by hypoxia slowly and probably not recognize the symptoms. The other one is an explosive decompression. And we go from 25,000 feet to 43,000 feet in 3 seconds, which is quite a bang. They go boof, and the cabin fills with moisture because the air at the reduced pressure can no longer hold that moisture. Now, we had a politician called Michael Portillo, just for anybody who doesn't know Michael Portillo, he's one of our more intelligent ex-MPs. Oh, he is, come on, be honest. He had gone to the States to look at the death penalty and the means of administering the death penalty. I'm not going to get involved in any debate on the rights and wrongs of the death penalty here, but his argument was that they would be able to dispatch people in a very, very painless manner here if they put them in one of these chambers rather than any of the other existing methods of execution. And he has a certain point to it. So this is what they do. They put us in this chamber here and they make us breathe pure oxygen to begin with for about 10 minutes before the exercise begins. This is to purge the nitrogen in the system. Remember the bends, if we have nitrogen in our body and we decompress, that nitrogen is going to come out of the solution in our blood and cause us the bends. In other words, that excruciating pain in our joints. It depends, as I say, on how long you can hold your breath once you get above a certain altitude. It doesn't really matter how long you can hold your breath at ground level. Once you're at high level, the oxygen is actually going to vaporize off the tissue in your lungs. So your time of useful consciousness is much less than you could achieve by holding your breath at ground level. So this are the face masks that we use to breathe oxygen, pure oxygen, before we start going for the high altitude run. So this is my call: ethical execution or exit of choice. I mean, if you're terminally ill, this would be the way that I would choose to go, I'll tell you. It's absolutely painless and it's rather fun. I'm going to have to run on a little bit here, but this is Michael's trip in the decompression chamber. You'll notice that the point of decompression, as I said, you get a boof, and then you will get this misting in the cabin. And this will be your first indication if it ever happens to you on board an aircraft. So this is Michael doing his run in the cabin.
This is a risky experiment, as unconsciousness can occur quite suddenly.
That was a sudden change.
This is what we call regular compression. Just recover, so...
Double return periods. A little bit giddy. Okay. Yeah, a little bit lightheaded.
Physiologist Dr. Hans Wittenberg is monitoring Michael's condition.
I feel
by asking him to complete basic tasks.
Can you show me by sticking up your fingers how much 9 minus 5 is?
9 minus 5 would be 4.
Excellent. What card is this?
That's the Ace of Clubs.
Excellent.
Yeah.
Michael's brain is suffering from oxygen starvation, making him feel drunk, euphoric, and overconfident.
Can you hold this up for me?
I can hold it up, yeah.
And can you put the shape in it as well?
Alright, I'm looking for... I can't see that one.
That's here. You see? Look at it.
Okay.
Excellent. What kind of card is this?
It's the 3 of diamonds.
3 of diamonds?
Yeah.
What kind of shape is it? Can you put it in?
Yes, it's the star. Yes.
Michael will eventually face an ultimate test. Will he be able to switch his oxygen back on and save his life? Or will he be too far gone to care?
How much is 8 minus 3?
8 minus 3 is 4.
Is it 4?
8 minus 3... 8 minus 3 is...
Michael is dangerously hypoxic.
This.
Okay. I think it's time to recover, Michael. Can you put up the switches? 6 minutes. Put up the switches. We will die.
Just swing the mask back on.
He's experiencing what appears to be the perfect method of execution, and he doesn't care.
Put up the switches. We will die. Put up the switches. Can you tell me how you feel now? How do you feel?
I feel much better.
Very good. How much is 8 minus 3?
5, definitely. 5. Yeah.
Okay.
Okay, thank you. Michael.
Where are we now, Captain?
Well, actually you are descending now to sea level again. We are at 26,000 feet.
How much longer until I would be unconscious?
Well, a matter of seconds. I guess 10 to 20 seconds, and then
And from there to death?
that's your final destination then.
If heavens hadn't stepped in,
Yes. What do you think? It just shows how insidious this is and how you do not realize how it's affecting you. Just quickly, fatigue. Everybody suffers from fatigue at one stage or another. It can be short-term, in other words, acute, or it can be chronic, which is long-term fatigue. And pilots are quite susceptible to this because of these massive east-west sectors that we fly non-stop with massive time zone changes. The other thing that people ask me about are airborne infections. What is the quality of the air in the cabin like? The quality of the air in the cabin is better than the quality of the air you are breathing right now. I promise you that. In the aircraft you say, yes, but all the air is recycled. No, it's not. It's about 1/3 of the air which is recycled. The rest of it is fresh air taken into the air conditioning units and circulated. The bit that is recycled goes through what are called HEPA filters. These are high efficiency particle filters, the same ones that are used in hospital operating theatres. They actually filter out about 99.99% of any microbes or bugs or anything in the air. So the quality of the air in the cabin actually is quite good. The other one that we sometimes discuss is what we know as deep vein thrombosis, or DVT, economy class syndrome. It's not the economy class syndrome, I assure you. It does not simply happen to people in economy class. You could have a DVT sitting here, right now. There is some evidence that you may be at slightly higher risk, but not because you're travelling economy. It's because possibly you're dehydrated on board the airplane. You might have had a bit too much coffee before you get on board or on board. You might have had a few glasses of wine with lunch. That's going to dehydrate you. That's going to thicken your blood. So that is possibly going to predispose you to a slightly higher risk of DVT. Okay, if you've had a surgical operation recently, then you're possibly slightly more likely to have DVT. Any form of immobility is going to give you a slightly increased risk. The contraceptive pill and hormone replacement therapy, that can increase your risks. Older people, yes, they are more susceptible to it. Pregnancy will increase the risk. It's about 1 in 1,000 of pregnant women will have a DVT. Obesity will also increase your chance of DVT. But please be assured that all of these risks are extremely small. And I'll say, looking after yourself on board, try and get up at least every hour, walk up and down the aisle if you can, stretch your legs, and make sure you hydrate, make sure you drink plenty of water. Try and avoid alcohol. I don't want to be a killjoy, but not too much of the old demon drink. No sleeping pills. Do not use sleeping pills unless you absolutely have to. A, you're going to wake up feeling dreadful. B, you might not sleep with a sleeping pill in turbulence, which is going to make you feel even worse. Compression stockings, yes. Make sure you have them fitted by somebody who knows what they're doing, preferably your doctor. Tell your doctor you're going on a long-haul flight and you want to know about compression stockings. He will then give you a prescription for the correct pressure stocking that you need. What you need are the surgical ones, which they put on you when you've had surgery. They put those surgical stockings on for a very good reason, to stop the blood from pooling in your legs. You can get your doctor to give you something called heparin as an injection, which will thin the blood, but that has its side effects as well. So you want to be a little bit careful about that. Aspirin. People say, take aspirin. That'll thin the blood. It will thin the blood. There's no reason not to take aspirin, but it's probably not going to give you much protection against deep vein thrombosis. It may protect against deep arterial, in other words, in your arteries, thrombosis, but it's the vein which is going to cause you trouble if you have a particular clot which either gets lodged in your heart or in your brain. That is what is going to cause the problem. If it makes you feel better, by all means, take 75 milligrams, very low dose aspirin, 2 days before, the day of, and 3 days after your journey. Keeps the blood a little bit thin. Won't do you any harm unless you've got stomach ulcers or stomach complaints, in which case aspirin might just aggravate those. So after the journey, you want to try and get some exercise. Go for a little walk before you go to bed that night. The other thing was jet lag, which I was going to mention to you. There's no cure for jet lag. The only way you can get used to jet lag is to allow 1 day per hour of time zone change that you have been through. That's how long it takes for the body clock to adjust. The other strange thing is that your liver has its own body clock. Now, I'm not joking, it has its own body clock. So if you're used to having a glass of gin and tonic at 6 in the evening, and suddenly you're in a different time zone, and you're having a gin and tonic at what your liver's body clock time is 10 o'clock in the morning, it's going to get a bit of a fright. It's going to say, hello, what's going on here? A gin and tonic at this time of day? Surely not. And it'll have to wake up and go to work. As far as stuff like melatonin is concerned, if you've used melatonin, or if you want to use melatonin, which is the drug that tells your body whether it's day or night, get it from your doctor. Do not buy melatonin over the counter, because you have no idea what is in those things, and especially not from health food shops. I use health food shops advisedly. Get it from your doctor on prescription, then you know what you are getting. The only real cure for jet lag that I came across in many, many years, I was flying with a young co-pilot, and he was having the most awful problem with sleeping after long east-west sectors. And he asked me, he said, did you ever find a cure for jet lag, Captain? I said, well, yes and no, I suppose. I'm married to a much younger woman, and when I get to the airport, I just phone her up at home and tell her I'll be home in an hour. She gets the jacuzzi on, gets it all nice and hot. When I walk in the door, she greets me. She brings me a nice glass of malt whiskey, undresses me. We get into the jacuzzi, have a lovely massage in the jacuzzi. Then we adjourn to the bedroom, and half an hour later, I just drift off into the most wonderful deep sleep, and that's it. All sorted, jet lag sorted. So he said, "Oh, thanks, Captain." He said, "That's brilliant." So I was flying on again a couple of months later, and I said, "Did you try what I suggested?" He said, "Yeah." He said, "It was absolutely fantastic." He said, I cannot thank you enough." He said, "By the way, that is a fantastic jacuzzi you've got." Yes. Time to go home, I think. I think we're doing the final one on Wednesday, 22nd of May at 3:30. We're back in here again. So I hope that wasn't too serious for you, that talk there. The next one is it's quite fun. We look at glamour in the skies. Is the job glamorous? Has it ever been glamorous? Will it ever be glamorous? And we look at some of the other low-cost airlines, which are probably never going to be glamorous, I have to tell you. People have asked if I've flown a helicopter. I showed you this slide earlier, actually. I have flown a helicopter, but I don't like helicopters. It's the most unnatural way to travel. The only way a helicopter is better than a fixed-wing aeroplane is when you get that. It's lovely. All right. One for the boys, girls. I'm sorry. Thank you very much, everybody. Have a lovely day on board, and I look forward to seeing you later on. Thank you very much.